Okay, let's unpack this.
Today, we are undertaking a deep dive into an area that really defines rapid decision-making in the emergency department. We're talking about upper limb trauma.
Absolutely. I mean, these are some of the most common musculoskeletal complaints that walk or, are carried through the doors.
Mm.
And for you, our listener, whether you're a clinician just wanting to get some clarity on protocols or you're just someone who wants that expert level shortcut, this is it.
Right. We're looking at managing everything from a tiny fingertip injury all the way up to a major joint blowout. This material, drawn from foundational emergency medicine sources, is basically your practical roadmap.
And the mission today isn't just to describe these injuries.
No, not at all. We're moving past that. We're focusing on the critical timing, the nuanced X-ray cues, the potential for really life-altering complications, and, the exact sequence of management that's required.
That's the key distinction, isn't it? Upper limb trauma rarely threatens life, but its impact on function, on quality of life, it's just profound.
It is. It demands specialized immediate care. And that urgency, it starts with one non-negotiable rule that the sources just stress over and over again.
Which is?
Never delay analgesia. Yeah. Never. Not to allow for a better examination, not for an investigation. It is the bedrock of compassionate and, frankly, effective ED care.
I understand the moral side of that, I do, but practically. Let's talk about the real world. You have a multi-trauma patient or maybe an elderly patient who's already a bit confused.
Sure.
Isn't there a genuine concern that strong IV opioids might, alter their GCS, their Glasgow Coma Scale, that it could complicate the assessment of head injury or even mask a serious bleed somewhere else?
That is the historical entrenched belief. And the source material addresses it head on. It calls that concern inhumane and incorrect.
Wow, strong words.
Very. And the argument is this: severe pain and the distress it causes actually prevent the patient from giving you a reliable history. They can't cooperate with an exam, and they certainly can't tolerate the procedures you need to do, like a joint reduction.
So you're saying a calm, pain-free patient is actually a safer patient?
A calm, pain-free patient is a patient who can participate in their own diagnosis. It leads to a faster, clearer, and ultimately safer diagnostic journey. The clinical benefits they vastly outweigh that theoretical risk of masking signs.
Okay, so let's follow that patient. They've just come through the doors, they're in pain. The efficiency of the whole department really hinges on what happens next, right? Before a doctor even sees them.
Exactly. The formal protocol insists that every patient in pain is treated appropriately and immediately. And that process, it starts the moment they arrive, usually with a triage nurse.
We often think of the triage nurse as just, assigning a category, but their role in acute trauma is so much deeper. What concrete things should they be doing for an upper limb injury?
The senior triage nurse is really acting as an immediate diagnostician and stabilizer. They're initiating actions based on very clear protocols.
Like what?
For an injured arm, it's about stabilization and getting ready for imaging. So elevating the limb, simple, but so crucial for minimizing swelling. Applying ice packs to reduce inflammation and pain.
And splinting.
Applying temporary splints, for comfort and to prevent any more damage to the bone or soft tissues.
Right.
But most crucially, they're initiating the right X-ray orders.
And that rapid initiation of imaging, that's the real bottleneck breaker, isn't it?
It's the engine.
Getting those views ordered right away before the full history is even taken, it just sets the pace for the whole deep dive into their injury.
It really does. It turns that wait time into diagnostic time. A patient getting analgesia and already on their way to the X-ray suite. That is the definition of efficient, patient-centered care.
But even when the injury seems clearly isolated to an arm or a leg, we can't get tunnel vision.
Never. You always have to connect back to the overriding principles of major trauma management.
So even if the arm is visibly deformed, if the patient fell from a height or was in a car crash?
The first, non-negotiable step is always to rule out life-threatening issues. It has to be the standard CABCD assessment. Catastrophic hemorrhage, airway, breathing, circulation, stability, exposure. You manage and stabilize all of that before the team can even think about settling into the orthopedic detail of the limb.
Okay, let's pivot to an injury that just instantly elevates the risk profile. The compound or open fracture.
Right. A compound fracture is an infection risk. It's a surgical emergency, and it requires a specific immediate management bundle.
It's all about infection control.
That's right. The bone has communicated with the outside world, so the risk of a deep infection like osteomyelitis is incredibly high. The rule is immediate prophylactic FEA antibiotics.
And what's the general thinking on antibiotic choice in the ED for, say, a clean contaminated compound fracture?
But local policies will vary, of course, but the sources emphasize a broad-spectrum antibiotic. Often that's going to be something like a second or third generation cephalosporin. C. FRCEM is a common one.
But what if it's a really dirty wound, a farmyard injury, or something with a lot of crushed tissue?
Then you broaden your coverage. You might add a drug like metronidazole or maybe high-dose penicillin for anaerobic coverage.
Yeah.
The goal is just to get high tissue concentrations immediately.
And crucially, we have to talk about tetanus.
Tetanus prophylaxis has to be ensured for any wound, really, not just compound fractures, burns, deep lacerations, anything where you have contaminated, devitalized tissue. That anaerobic environment is perfect for Clostridium tetani spores to proliferate and produce that toxin.
So you have to check their vaccination status and give them what they need.
Absolutely. Tetanus immunoglobulin, the vaccine. It's a non-negotiable step.
The sources mention a critical classification detail for compound fractures that really changes everything. It demands immediate multidisciplinary surgical input.
Yes, the Gustilo-Anderson classification. It grades open fractures based on soft tissue damage and contamination.
And well, that's the most severe. It is a true limb-threatening emergency. And it's defined specifically as a compound fracture associated with a vascular injury.
That needs repair.
That phrase, needing repair, is so important. Why does that specific detail change the game so completely? It's not just an orthopedic problem anymore.
Because it introduces the surgical clock. A typical type 3A or MIB fracture, it'll go to the operating room for washout and fixation, sure. But a type I has compromised the viability of the entire limb distal to the injury.
Ischemia time.
Ischemia time is critical. This injury mandates immediate attention from both orthopedic and vascular surgeons, often working at the same time. Blood flow has to be restored within a very strict time window, ideally under 6 hours, to have any chance of salvaging the limb.
Okay, let's move on to imaging. Dislocations. This is a common dilemma for clinicians, right? Wait for the film or reduce the joint right now?
It is, but the standard practice, almost always, is to get an X-ray before you attempt reduction.
Why is that so critical?
Because you have to accurately identify the displacement pattern and, more importantly, rule out any associated fractures. If you try to reduce a dislocation that has, say, a big surgical neck fracture of the humerus with it,
You could make things much, much worse.
you could turn a complex but manageable injury into a catastrophic, non-reducible situation.
But that's the rule. Emergency medicine is all about knowing when to break the rules. What's the one scenario where you abandon the X-ray and just reduce immediately?
If there's considerable neurovascular compromise, that phrase is the universal trigger,
Meaning?
meaning the distal pulses are absent or the patient has a sudden, progressive neurological deficit. Signs that the vascular supply or the nerve function is actively being crushed or stretched.
So the priority shifts completely.
Completely. You can't wait for imaging. Minutes matter for limb viability. The experienced clinician makes the call, gets rapid analgesia and sedation on board, and proceeds immediately with reduction to restore that blood flow and relieve the pressure.
Let's move now to the high-volume, high-consequence stuff, major joint injuries. Starting with the shoulder. Anterior shoulder dislocation is, well, it's by far the most common major joint dislocation we see.
It is, and the mechanism is highly characteristic. It's forced external rotation and abduction.
So like a football tackle where the arm is yanked outwards and back?
Exactly that. It levers the humeral head right out of the glenoid fossa.
Yeah.
You typically see it in younger, more active patients.
And the clinical presentation is often so classic you can almost diagnose it from the doorway.
You really can.
Mm.
You look for that immediate guarding. The patient is cradling the affected limb with their uninjured arm.
Visually, what are the signs?
The normal rounded contour of the deltoid muscle is gone. It's replaced by this flattened appearance, which gives you the step-off deformity at the acromion.
And if you palpate,
Crucially, if you palpate, you'll often feel an abnormal empty gap right below the acromion, where the humeral head should be. And the head itself is often palpable anteriorly, maybe under the clavicle or deep in the axilla.
the clinical diagnosis is strong, but the X-ray confirms the specifics. What are we looking for on that film?
The X-ray, usually an AP and a lateral view, will confirm the humeral head is lying anteriorly and a bit inferiorly to the glenoid. But we're actively looking for two specific associated injuries.
Which are?
First, the Hill-Sachs lesion. This is a compression fracture on the back of the humeral head. It's caused when it impacts against the front rim of the glenoid during the dislocation.
And why does finding a Hill-Sachs lesion matter for management?
Well, its presence, especially if it's large, tells you there was a significant degree of force involved, and it might influence the likelihood of recurrence down the line.
Okay, and the second lesion.
The second is a Bankart lesion. This is an injury to the anterior inferior labrum, that little cuff of cartilage that deepens the socket.
And you can see that on an X-ray.
Not usually, but
Yeah.
just soft tissue. But a bony Bankart lesion, which is a fragment of the glenoid rim that's fractured off, is clearly visible. And that indicates significant instability, which definitely affects long-term stability and follow-up.
So once it's confirmed, the plan is all about a swift, controlled reduction.
Exactly. The plan is sequential. First, immediate and generous analgesia and muscle relaxation. Procedural sedation is ideal. The goal is early reduction to minimize any neurovascular strain and reduce the risk of it happening again.
And there are a few ways to do it, right?
Oh yeah, the sources detail several established techniques. You might use the Stimson technique, where the patient lies face down and the arm hangs off the bed with a weight attached. It relies on sustained traction and gravity to tire the muscles out.
What about a more active maneuver, like the kosher technique? I hear that's fallen out of favor a bit.
It has, a little. The Kocher technique involves a very specific sequence of rotations and flexion. It can be effective, but it carries a theoretical risk of causing a fracture or neurovascular injury if it's not done meticulously and gently.
So what's preferred now?
Many clinicians prefer safer, lower force methods. Simple external rotation or traction, counter traction with a bedsheet. The principle is always the same. Be slow, be deliberate, be gentle. You're waiting for that muscle spasm to release.
And once you hear that satisfying clunk that tells you it's back in, what are the two critical, immediate next steps?
First, an immediate and meticulous recheck and documentation of the distal pulses and sensation. You have to specifically check the axillary nerve function, that's the sensation over the deltoid, which can get stretched.
And second?
Second is immobilization. This is done with a POP back slab, a posterior slab in a sling. That's for comfort and short-term stability.
Oh,
Then they get a referral to the fracture clinic for their rehab planning.
why a back slab and not a full circumferential cast?
That's an excellent question. A back slab is preferred in the acute phase because it allows for swelling, and swelling is a certainty after a major trauma and reduction. A back slab prevents the cast from becoming a tourniquet, which avoids the catastrophic risk of compartment syndrome.
Makes sense. The full cast is for later, if needed.
Exactly. Once the swelling has gone down.
Okay, let's move to the elbow. Elbow dislocations are less common than shoulders, but they're inherently more complicated.
They are. The tight packing of neurovascular structures means the risk is just higher. They are typically posterolateral dislocations.
And unlike some clean shoulder dislocations, X-rays here are pretty much non-negotiable before reduction.
Almost always mandatory, yes, because there's an extremely high incidence of associated fractures, radial head, coronoid process, epicondyle fractures. If you miss one of those, you can severely destabilize the reduction attempt.
So once a pure dislocation is confirmed, what's the management path?
The goal is prompt, general reduction under adequate analgesia and sedation. The technique usually involves steady axial traction combined with reversing the path of the displacement.
And how do you know you've been successful?
Two things. First, that palpable plunk, and second, the restoration of the normal bony triangular relationship.
Can you explain that triangular relationship?
Sure. It's a key anatomical landmark check. In a normal elbow, especially when it's flexed, the medial epicondyle, the lateral epicondyle, and the tip of the olecranon form a very stable, predictable triangle. Once the joint is reduced, that relationship is restored. It's a palpable and visual confirmation that's often more reliable than a quick clinical exam on a sedated patient.
Post-reduction care for the elbow seems particularly vigilant.
It has to be.
Yeah.
Immediate recheck of pulses and sensation is mandatory. The arm is immobilized in an above-elbow POP back slab, usually set at about 90 degrees of flexion.
And the big concern is swelling again.
Huge concern. The sources really emphasize the risk of significant swelling and compression within those tight fascial compartments. We're worried about Volkmann's ischemic contracture,
Which is?
a catastrophic complication. It's muscle necrosis due to an unrecognized compartment syndrome. Because of that risk, admission for observation and serial neurovascular checks is often considered, especially if it was a high-energy injury or a difficult reduction.
And if you can't get it reduced in the ED?
If you can't reduce it after a couple of gentle attempts, or if the X-ray shows gross instability, it's an immediate referral for reduction under general anesthesia in the operating theater. More forceful manipulation in the ED just risks catastrophic damage to the neurovascular bundles or the joint itself.
Okay, now that we've covered the acute high-energy stuff, we should remember that not all severe shoulder pain is a fracture or dislocation.
That's a crucial point. Let's shift to the common soft tissue mimics we see that often present like pseudotrauma.
First step?
Subacromial bursitis. This is when the bursa, that little fluid-filled sac that lubricates the shoulder, gets inflamed. It often presents acutely, usually after some unaccustomed repetitive activity.
And what's the clinical signature for bursitis?
The classic finding is the painful arc. The patient gets severe pain when they lift their arm out to the side abduction, specifically between about 60 and 100 degrees.
And how do we manage that in the ED?
It's simple, conservative therapy to start. NS aids for the inflammation, ice, and encouraging simple passive exercises. The source specifically recommends gentle pendulum swings and crawling fingers up a wall to gently restore that range of motion.
What about an injection?
A local anesthetic injection into the bursa can provide immediate pain relief and is often diagnostic. If it works, you've pretty much confirmed it.
Okay, what's the other common presentation? Usually affects a slightly older group or people in heavy manual work.
That would be rotator cuff tendinitis or tendinopathy. This is about overuse or chronic injury to the rotator cuff tendons. Clinically, it has a longer history, chronic pain that often disturbs sleep, and a reduced range of active movement.
Do X-rays help at all here since it's a soft tissue problem?
They do, but indirectly. The main reason for the X-ray is to rule out bony trauma. But you might see secondary findings like osteophytes or subchromial calcification, which point towards chronic impingement.
And the management path is different from bursitis.
Precisely. While NSAIDs are helpful for severe chronic cases, the crucial intervention is a formal, structured physiotherapy referral. You need to strengthen the dynamic stabilizers of the shoulder. The ED's role is diagnosis, pain control, and getting them to the right follow-up.
Okay, now let's descend into the really complex microanatomy of the hand and wrist. This is where small injuries can cause massive functional disability.
It really is. Let's start with a mechanically challenging one. The thumb MCPJ dislocation, metacarpophalangeal joint.
Usually from hyperextension.
Yes.
Yeah.
Once you've got your X-rays and a good local anesthetic block, the goal is reduction. But the key is what you do after successful reduction.
Which is?
The immediate focus is stability. You have to assess and document the integrity of the collateral ligaments, especially the ulnar collateral ligament, the UCL, which is critical for pinch and grip strength.
And if it's stable?
If it's stable, you immobilize the thumb in slight flexion about 15 degrees in a POP splint and arrange follow-up.
But what if you can't reduce it? The sources mention a very specific mechanical block.
Yes, this is a major red flag. Unsuccessful closed reduction suggests buttonholing. This is where the head of the metacarpal bone has actually passed through and gotten tracked by the surrounding soft tissues.
So the tissue is literally buttoned around the bone.
Exactly. The volar plate, sometimes the tendons, they physically block any attempt at traction or reduction. You cannot force this. It dictates an immediate referral for open reduction in the operating theater.
Let's move to the carpus, the fractured hook of the hamate. A classic diagnostic trap.
It really is. It often comes from holding something like a tennis racket or a golf club during a powerful swing.
And it's so hard to spot on standard wrist x-rays.
It is. It's tucked away on the palmar side, often completely obscured by the other bones. The suspicion comes from highly localized palmar tenderness. You often need specialized imaging, a carpal tunnel view x-ray, or, more reliably, a CT scan.
And why is this tiny fracture so important?
Because of what's right next to it. The hook of the hamate forms part of the carpal tunnel, and the ulnar nerve runs directly adjacent to it. A non-union or a chronic fragment can lead to ulnar nerve compression, causing long-term weakness and numbness.
So it's immobilization and an urgent referral to a hand specialist.
Every time. The risk of nerve complications is just too high.
What about smaller open injuries in the hand, like a distal open phalangeal fracture?
There, the emphasis is all on wound management and infection prevention. Meticulous wound cleaning, often with high-pressure irrigation, followed by closure and prophylactic antibiotics. These are often managed entirely in the ED.
And finally, those tiny, easily missed avulsion fractures.
The flake avulsion carpal fractures, often the triquetrum bone on the back of the wrist from a sudden hyperflexion. They're tiny, but they need to be diagnosed. Management is simple. Immobilization in a POP back slab, pain management, and fracture clinic referral.
Okay, the functional integrity of the hand really comes down to its tendons. Let's start with extensor tendon injuries.
Right. These are generally a bit easier to assess and repair because they lie more superficially. If the division is more than 50% or complete, it needs a primary repair.
Can that be done in the ED?
In some well-resourced departments with experienced staff, yes, it can sometimes be done under local anesthesia. After repair, you have to immobilize the hand in a volar slab with the finger joints in full extension to take tension off the repair.
And now for the big one, flexor tendon injuries.
These are the true surgical emergencies of the hand, and clinical assessment can be notoriously misleading.
Why is it so hard to assess a divided flexor tendon at the bedside?
The main reason is pain avoidance. The patient will often refuse to even try to flex the digit because of the pain, so the examiner might mistakenly think the tendon is intact.
So if you have a high suspicion.
If you suspect a division of more than 50%, the text is clear. Clinical assessment is not enough. Exploration under anesthesia is often necessary to confirm it.
You mentioned flexor tendon zones earlier.
Yes, the hand is divided into 5 zones. And Zone 2, which runs from the proximal palmar crease to the middle phalanx, is historically called no man's land.
Why such a dramatic name?
Because in Zone 2, 2 different flexor tendons run inside a single tight common sheath. An injury there risks scarring both tendons together and to the sheath wall, which can lead to a permanent severe loss of function. Repair in this zone is technically demanding and needs a specialist hand surgeon.
Let's cover 2 specialized high-risk hand wounds. First, the infected wound from a punch over the knuckles.
The clenched fist injury, or the fight bite, a critical diagnosis. These are often human bite wounds, highly polymicrobial, and they often present late with an established deep infection.
And the mechanism is deceptive.
Very. The small cut happens while the hand is clenched. When the hand relaxes, the cut structures retract, trapping bacteria deep inside the joint space or the tendon sheath.
And the managed.
Non-negotiable. These require immediate referral for theater exploration, washout, and debridement. And you need antibiotics that target human oral flora. You do not close these wounds in the ED.
Finally, ring avulsions and finger pad amputations.
Any circumferential or significant degloving injury, especially a ring avulsion, needs an immediate, urgent referral to a reconstructive surgeon. These are often severe vascular injuries.
And for finger pad amputations.
There's a pragmatic rule of thumb. If the skin loss is less than 1 square centimeter and there's no bony exposure, it can often be allowed to heal by itself with simple, non-adherent dressings. Anything larger often needs advanced intervention, like a skin graft.
We're coming full circle now, back to our starting point, pain relief. The ability to do effective, targeted regional blocks is really a hallmark of high-level emergency practice.
They're procedure gold. They offer targeted pain relief that often outlasts IV opioids and provides a much better environment for manipulating a fracture or repairing a complex wound.
Let's talk about the digital nerve block, essential for any finger procedure. What's the crucial contraindication?
We typically use standard local anesthetics like lidocaine or bupivacaine. The crucial life-saving contraindication is the use of adrenaline or epinephrine in these blocks, especially in patients with peripheral vascular disease, diabetics, smokers, people with Raynaud's.
Can you explain the physiological risk there? Why no adrenaline?
Adrenaline causes potent vasoconstriction. In digits, the blood supply is predominantly end-arterial, meaning there aren't many collateral vessels. If you inject adrenaline, that vasoconstriction can be severe enough to cause tissue ischemia and then necrosis.
You could cause them to lose the digit.
You could, which is why its use in digital blocks is prohibited as a general principle. It's just not worth the devastating risk.
Okay, next up, the radial nerve block at the wrist. How does that one work?
The radial nerve runs superficially as it crosses the wrist on the thumb side. So the block is done by infiltrating the local anesthetic subcutaneously, forming a sort of ring or wall across the back and radial side of the wrist.
And its characteristics.
It has a very rapid onset, which makes it ideal for procedures on the back of the hand and the thumb, but it has a shorter duration compared to median or ulnar blocks.
Finally, the source mentions the Beers block intravenous regional anesthesia.
Yes. A Beers block is a technique where you put a tourniquet on the limb, drain the blood out, and then inject local anesthetic intravenously. It anesthetizes the entire limb distal to the tourniquet.
And the source links this to sickle cell disease testing.
It does. Because the blood is excluded from the limb during the procedure, it creates a localized hypoxic environment.
And low oxygen is a major trigger for sickling.
Exactly. It can precipitate a localized sickling crisis within that limb. So the source material mandates that before you do a Beers block in an at-risk patient, particularly those of African or Mediterranean descent, a sickle test has to be performed to confirm their status and prevent a potentially catastrophic complication.
Beyond the immediate trauma, it's meticulous documentation and basic infection control that really define quality care.
Absolutely vital. You have to record the exact nature of the wound laceration, abrasion, crush its precise size, and its position. It's essential for continuity of care, for legal protection, and for monitoring how it heals.
Let's just reiterate the tetanus principle one last time. What's the environment in a wound that promotes that deadly risk?
It's the presence of heavily contaminated wounds with devitalized, non-viable tissue. That creates a low-oxygen anaerobic environment, which is ideal for the proliferation of Clostridium tetani spores and the production of that neurotoxin.
We often treat facial injuries alongside upper limb trauma, like in a fall, and facial wounds present a unique challenge. The priority shifts dramatically.
It really does.
Hmm.
In facial wounds, the priority shifts from aggressive debridement to cosmetics. Cleaning is crucial, but unlike a dirty limb wound where you might cut away tissue, the text specifically advises against that in the ED for the face. The goal is accurate, tension-free opposition of the wound edges.
And there's specific advice on when to take the sutures out for the best result.
Yes. For optimal cosmetic results, the skin sutures have to be removed early, specifically in 3 days. Then you immediately replace them with steri strips.
And the rationale for that.
The skin edges only need about 72 hours to achieve initial stability. Removing the sutures that quickly minimizes the foreign body reaction in the skin, which is the main driver of those prominent train track scars.
What an extensive ground we have covered today. I mean, we went from the foundational ethical need for immediate analgesia all the way to the fine surgical detail needed for flexor tendon injuries.
We really did. From type IF vascular emergencies, through the mechanics of joint reduction, down to specialized bite wounds in the hand.
I think the synthesis here for you, the listener, is just the incredible speed and precision required in the ED.
It is. We see how these seemingly minor clinical details, the mechanism of a punch wound, that localized palmar tenderness hinting at a hook of hamate fracture, each one dictates a dramatically different, time-sensitive referral pathway. Emergency medicine is really the art of pattern recognition, just applied at high velocity.
I think we should end today by looping back to the idea of safety and a confident discharge. We focus so much on the acute intervention, but the decision to send a patient home, that's arguably the most critical and often the most invisible phase of care.
That's absolutely right. Let's recall a specific piece of advice from the source material for low-voltage electrical injuries, a type of trauma that often involves the upper limb, but can leave almost no external sign.
Okay.
For an asymptomatic patient with a normal ECG and no cardiac history, the source states they can be discharged safely because, and this is the quote, late-onset arrhythmias are very unlikely.
That one phrase is pretty profound. It's not just a medical fact. It represents the physician's confidence in their exclusionary practice.
It is. It reminds us that every discharge decision, even for what seems like minor trauma, is an active clinical statement. It means you have confidently excluded the immediate, the secondary, and the delayed complications, like those unseen arrhythmias or a miscompartment syndrome, that could arise after the patient leaves your care.
So the goal isn't just to fix the injury in front of you.
No. It's to gain the knowledge required to confidently predict and prevent the next complication. That is the true value of meticulous emergency medicine protocol.
An excellent thought to end on. Thank you for guiding us through this essential deep dive into the complex world of upper limb trauma.
My pleasure. Stay well informed, and we'll catch you on the next deep dive.